Thank you very much for the kind invitation. I'm still looking forward for someday coming to your beautiful country, especially on days like today where we have minus 20 degrees here in Canada. And I got this catchy title to talk about the dreaded duo, rejection and coronary allograft vasculopathy. And if you look at it, yes, it is a mean duo, but reality is it mostly comes with more of its kind and their mean brothers infection and non-adherence. So what I would like to talk to you about is immunology of graft injury, just very briefly to give you some insight into how they kind of play together, acute rejection, types and consequences, graft vasculopathy, where it comes from and what it causes, clinical aspects and diagnostic approaches of the two, and then prevention and management of rejection and graft vasculopathy. So let's start with the immunology. And I like to compare the innate immune system with a police riot squad. It's formed of granulocytes, phagocytes, natural killer cells, and complement, but it really is always available, very fast system to hit basically on everything that seems foreign. So it's not very specific in its response, and it's rather crude, and it also doesn't learn. So it will always attack the same things, no matter whether they're good or bad, just whatever it's been brought up to keep in check. The pathways it has to harm something that is recognized as foreign is induced apoptosis and enzyme-mediated injury, direct membrane attack using the complement system, opsonization, which is basically like dipping a strawberry into chocolate, so it makes it more likely that you eat it, and therefore it makes it more appetizing to antigen-presenting cells. And then chemotaxis is a really important part as well, because basically there's a gradient that evolves that tears or lures other immune cells into the heat of the action towards where the inflammation takes place. This part of the immune system really plays a big role in the very first time after transplantation in ischemia reperfusion injury, when an organ comes out of the cold and out of foreign body into this new organism, and recent activities aim towards using machines that allow the organs to warm up and be perfused in a less harmful environment for a while, and seem to improve or reduce that aspect of the immune response to the graft. The adaptive immune system is much more comparable with a joint group of criminal investigators. It has the T4 helper cells as kind of the mind and central organizers. It has the antigen-presenting cells that provide the background information. It has the effector cells, which are the CD8 cytotoxic cells, and the B cells that produce antibodies. And it has somewhere in the background a smart instance that keeps everything from going overboard, the regulatory T cells. And it is important to keep in mind that this part of the immune system very closely works together with the innate immune system, both in terms of diagnostics and finding foreign organisms, as well as in managing them. The primary target of the adaptive immune system, as we've just heard from Tanuja, is the major histocompatibility complex, or in humans, the human leukocyte antigen, but also there's antigen response to the ABO blood group system. It's an antigen-specific response. It's self-optimizing, so there is a mechanism to find the best and most efficient clone. It forms memory, so the next time around the same antigen comes back, it's already ready to go, similar to a vaccination. But for the first time response, it takes a while, and this is an average about 3 weeks until you get a full response. And just coming back to what Tanuja already mentioned, it's important to separate HLA in class 1, which is present on basically every cell except for red blood cells in the body, and is detected by cytotoxic T cells as well as NK cells, and basically reflects an ID card that identifies the cell as self and clean, so being free of viruses and tumor degenerations. And class 2 has a role in the immune system itself, but is not present on all cells, but only on antigen-presenting cells. Interestingly, that includes the vascular endothelium, so it's also quite relevant on our transplanted organs. And that has a key function in communication between immune cells. So if you take a HLA antigen, and this is just going back immunology 101, it is typically presented in an antigen-presenting cell to a CD4 T cell which then has two main pathways of activation. One is to activate cells, the macrophages that have ingested those foreign antigens, as well as the cytotoxic T cells that target cells that are identified as not in a normal stage or foreign. And on the other hand, the B cells, if they have found the same antigens, they can be activated to produce antibodies, to go also into monoclonal proliferation, form plasma cells, which are the actual antibody-producing cells, and memory for future encounters. The adaptive immune system uses also the T8 effector T cells and NKT cells, and they harm cells directly by excreting mediators of direct injuries, such as granzymes and perforins and tumor necrosis factors, and also induce apoptosis and necroptosis, which is basically a programmed suicide of the cell by using respective receptor signals. Antigen-presenting cells then take these cell fragments or full cells and take these antigens and present them to CD4 T cells, thereby activating and enhancing all of the pathways further. And B cells, one important thing that often gets forgotten, are also antigen-presenting cells. So they themselves actually can present antigens and activate T cells, but they also are the origin of specific antibody production once they have transformed into plasma cells. How do antibodies harm? Antibodies, the classic pentamer of IgM, basically just agglutinates different cell types or bacteria or others, such as red blood cells, and it inactivates them that way. But there's other roles of antibodies, such as neutralization, so binding harmful substances so they cannot access their receptors on the surface. Again, opsonization, making it more likely that structures get ingested by antigen-presenting cells, and activating the complement system, which by itself puts direct harm onto the cells and destabilizes them. Now, what happens during acute rejection? This cartoon actually seems to depict something called hyperacute rejection quite literally, and it's something that happens extremely rare. I've only seen it once in my career, but seems to be an extremely obvious response of the immune system right at the time that the organ goes into the recipient circulation. Mostly it's probably has been in the past when antibodies were not recognized in the preparation for transplantation, and it goes along with irreversible damage. I brought these echoes from the one patient that I have experienced, and as you can see, there is barely any life left in that organ, and it's most of the time not a recoverable situation. Fortunately, it's extremely rare. Much more common are more subtle forms of rejection. This just shows you a healthy myocardium, and in 2005, the ISHLT has unified the classification of rejection. So while here you have the healthy muscle cells with some cores in between, some blood cells, mild acute rejection would be determined by one single focus of lymphocyte infiltrates that you can see here, together with some damage to the myocytes. That's limited to one focus, you call it 1R, and it usually does not go along with an worse long-term outcome for the graft, so it doesn't require any specific therapy. If you have multiple of those foci, it becomes a grade 2R, and if you get into a situation where you have diffuse infiltrates with diffuse injury of the myocardium, as you can see here, where basically the architecture of the muscle is completely dissolved, then it's becoming a 3R, often associated with edema, hemorrhage, and vasculitis. One thing to be aware of is this somewhat bizarre finding of the Quilty lesion that we have in almost half of our patients or biopsies, which is an accumulation of CD4 T cells underneath the endocardium. And it's actually macroscopically visible sometimes as a small pimple. It does not seem to cause harm, but it's really not well understood. It does not go along with myocardial injury, but it's a bit strange why all these T cells are just hanging out there in the heart. The second part is the antibody-mediated rejection. So antibodies that could have been formed earlier on in response to a homograft or in response to the organ can activate complement system, as I mentioned before. And this is one of the factors that we use to identify antibody-mediated rejection by using immunofluorescence to stain these fraction or split products of the complement system, C4D and C3D. both work about equally, and you get these nice kind of donut shapes around the vessels that indicate that complement has been deposited here. You could also use IgG similarly. And then you have microscopic signs of antibody-mediated rejection and immunohistochemistry signs of antibody-mediated rejection. And if you have both of them, you get a stage 2. And again, if you have damage, then you get a stage 3. What about graft vasculopathy? So one of the things that's important in keeping with this title is that the two are actually closely linked. This is an adult study that has looked into T-cellular rejection scores, just accumulating what happened in the first year, and found that the more higher grade rejections there were, the higher was the likelihood of getting graft vasculopathy. Similar study has looked into antibody-mediated rejection in children and found that patients that had multiple episodes or episodes of significant antibody-mediated rejection tend to have a very high likelihood of developing graft vasculopathy quickly. Why is that the case? Because as I mentioned, antibodies don't only activate the immune system and the complement system, but they also do this opsonization effect. So they actually lure antigen-presenting cells and macrophages into the vascular wall. There's more CD4 T cells coming on top of that, more B cells. There's a generally very inflammatory environment. We get fibrosis, we get endothelial swelling, and then the vascular wall becomes thicker and thicker. And with that, our lumen becomes narrow and narrow. So here you see an uninflamed vascular wall, and here you see what happens during graft vasculopathy. How does that look by angiogram? So this is kind of classical graft vasculopathy, where you have major narrowing similar to coronary disease in an adult, where you see narrowings at multiple levels here of the left main coronary artery, as well as the left anterior descending branch and the circumflex. And on the right artery in this patient, you could see that there is basically a sudden arrest of the right coronary artery, where it peters off to about 90% narrowing. The ISHLT has also come up with a nomenclature for this, and they give the first 2/3 of each coronary, as well as the left main, the title of a primary vessel, while the ones further downstream are called secondary vessels. And then there is a nice graduation that starts with mild if you have not so significant narrowings and not so widespread, to severe when you find more than 50% narrowing of the left main or more than 70% stenosis of some of your primary vessels. The important thing for children is this small sentence here at the end, which says evidence of significant restrictive physiology, automatically makes you a CAV grade 3 as well. And why is that? Because often in our children, when we look at their angiograms, we actually don't see any circumscript narrowing. So this is a nice example of overall smaller looking coronaries and rarefied smaller vessels, but you don't see any kind of circumscript narrowings as you've seen in the previous angiogram. And similar here on the right side, you can see that the main vessel actually looks quite pretty, but the vessels that come off here are nearly occluded and much smaller and much rarefied than what you usually would expect. Instead, you can see how the contrast really sticks in here, including in the coronary itself, and has a hard time to get through the small vessel. So this is a typical pattern of small vessel disease graft vasculopathy, which is the most common form that we see in the pediatric patients. To get a bit of a better insight into this graft vasculopathy, people have tried different techniques. Intravascular ultrasound has been around for a while. It's limited to larger patients. They should probably be somewhere in the 40 kilo range at least. And it gives you a not super fine, but visible picture of your intimal thickness. And it was shown in studies that if you have thickening of that intima and media combination that you see in that technique early on, it correlates with later graft vasculopathy or earlier onset graft vasculopathy. A much more pretty technique has recently evolved, which is called OCT, optical coherence tomography, using infrared, the same technique that is used to do pictures of the retina. And as you can see here, while you pull that back automatically and fill the coronary with contrast, you can actually nicely see both layers, the intima and the media, of the whole vessel and all the way around of this 4 to 5 centimeter area that you cover while the catheter retracts. And it allows you to basically microscopically differentiate the walls and intima and media and use the measurements that we are knowing from previous pathological assessments. Lastly, a complicated measure that again is only possible once you're like 40, 45 kilos of a patient is coronary flow reserve. In this situation, you actually enter a catheter down the left anterior descending coronary, and you measure the flow before and after you give adenosine. And usually you would expect that with adenosine, you open up your small vessels and get a faster flow. And that does not happen in patients that have small vessel disease. Now, I don't want you to look through all of this. This is really just to illustrate that it's not as simple as I showed you with that cartoon, that it's all immunological, but there's many factors that play into the development of graft vasculopathy, starting from the ischemia reperfusion injury over the need of immune suppression that then again puts you at risk for certain infections, the immune response kind of balance that you have to get there. You have vascular surface injury during the process, as well as in the context of hyperlipidemia and hypertension. There's metabolic and genetic factors that play into it, and your choice of immune suppression for sure plays into it as well. What are the clinical aspects and diagnostic approach? So one of the things to keep in mind is it depends on where you are after your transplantation. Acute rejection is really a thing of early transplantation and barely plays a role in long-term transplanted hearts, with few exceptions. Graft vasculopathy is something that increases more and more over time, and there's this obscure graft failure, which probably reflects small vessel disease, graft disease in many of the cases as well. So if you take that together, for sure, graft vasculopathy puts your biggest risk on the long-term survival and well-being of your patients. In children, we also know that once we're beyond the first year, if we use our standard combination therapies, it's very rare that we experience unexpected acute rejection. Most of the time when we see it, it is actually associated to inappropriate immune suppression, be it because of the patient not taking their medications, be it because of other medications interfering, or other health products or food that has interfered with the medication. It's also important how old the patients are. The younger they are, the fewer they experience graft vasculopathy. So as you can see here, the 1-year-olds and the up to 5-year-olds have less than 30% 10-year probability of graft vasculopathy, while the teenagers experience a very similar curve as is seen in adult patients. How does a patient in rejection present? It is not very specific, unfortunately, and has overlap with many other things. So typically you would see reduced activity, some malaise, tiredness, often fever and signs of infection. And that infection may be just a false infection as a sign of the rejection happening, or it could have been the trigger for the rejection that was there first. Poor eating, abdominal pain and vomiting, sweating, signs of heart failure. And then always important to look into the history of triggering events. Did they have a gastrointestinal infection? Do they have a recent CMV infection? Varicella is one of the viruses that can trigger rejection. Therapeutic changes. Did somebody give them medication that didn't work well with what they had? And adherence, are they actually taking the medications that we want them to take? In terms of ECG, again, very non-specific, but fairly sensitive. There's almost never a rejection without an abnormal ECG, a significant rejection. Typically, you could see PR prolongation, you could see new onset bundle branch blocks, like in this case, and you typically see a low peripheral voltage as well as precordial voltage. If you look at the echo, the systolic function often does not look very unusual, but as you visually notice here is this kind of snappy motion with almost like hitting a wall in diastole, very stiff diastolic function and associated abnormal diastolic function tests. And very common, you will have new onset aortic or mitral regurgitation. Graft vasculopathy is much more tricky to capture. Once it's really severe, it basically presents like coronary heart disease. So you will have a reduced ejection fraction, local wall motion abnormalities, You can have valve regurgitation, increase in left atrial size, and right ventricular systolic pressures. But it is much more difficult to detect it early on, and if it's more subtle, E to E prime combination of flow and tissue Doppler has been shown to be reasonably predictive, but not as reliable in children. There's various ways of assessing strain and diastolic strain. And we've recently noticed that the RV systolic and diastolic function appear to actually be abnormal about 6 to 12 months before we detect the graft vasculopathy. So maybe a great way to get an early detection. You can try a lot of high intensity testing as well. The butamine or exercise stress echo is reasonably useful in adults. In children, it has a very low sensitivity, and not many places continue to do it regularly. CT angiogram is being discussed for years now in the adult world, but has no convincing data yet that it is equally predictive as an actual angiogram. Echocardiography for coronary flow reserve has been described in a few papers, but you can imagine how difficult it is to get a coronary flow on an awake child with a transthoracic echo, so probably not a very easy technique either. In our center, we tend to do stress MRIs, which are shown to be very well correlating with acute rejection, but so do many other tests. For graft vasculopathy, I think the verdict is still out there, how useful they are. Definitely, you can see perfusion deficits, you can see progressive fibrosis. You get a more holistic view than with a biopsy because you see the whole heart. And you can use actually similar perfusion indices to see how fast the contrast passes into the small vessels with stress testing, and whether there is something that's suspect of small vessel disease. Besides the degree of narrowing of the vessel, shown in this nice paper by Steve Kindle, looking at a large number of patients assessed, it is important to take the physiological effects into account. So yes, the higher grade you have a narrowing, the worse is your prospective survival. But even as much or maybe more is the situation if you have elevated right atrial pressure or elevated wedge pressure, suggesting diastolic dysfunction. Diastolic dysfunction is a very negative prognostic sign once you have any degree of graft vasculopathy. It's also important how old you are when you develop it. Sadly, although they get it less commonly, the younger children tend to have a much faster progression once they experience graft vasculopathy, accordingly require more aggressive treatment if it's detected. Now, what can this treatment be, and how can we manage and prevent rejection and graft vasculopathy? Now, one of the things, if you have a situation where you think a patient has acute rejection, should always be admitted to cardiology and go on full monitoring. You would want to do your echocardiogram and ECG, and you would want to do a biopsy as soon as you can. If you cannot get a biopsy within a day or two and you're quite convinced or have clear non-invasive signs of a rejection, you would want to start treating and not wait for the biopsy. We don't recommend to do a coronary angiogram while you are in the acute situation of a rejection. The reason is that the coronaries are very sensitive and tend to have spasms, and these spasms can lead to cardiac arrest. And therefore, the coronary angiogram should be postponed until the patient is out of the acute situation of rejection. In terms of symptomatic acute rejection, even if it's only grade 1R, here we would treat, and we would typically use IV steroid, and I think that's pretty uniform basically around the clock. It's also in the Pediatric Heart Transplant Society recommendations. It's basically the first step almost everybody uses. If that's enough and they come out of their rejection, you can consider to either give a little bit of maintenance steroid for a short period or increase the maintenance immune suppression by 10 to 20%. If you have a situation where you have a clear reason why somebody was rejecting, like, for example, they have not been in target with their tacronymus level, all you need to do probably is make sure that they are back in the level that you would want them to be on. If they do not recover, typically you would repeat a second IV steroid course. If that still doesn't do the trick, you can escalate to antithymocyte globulin. And if that doesn't help, I think we're nearly out of options. One thing that's important, infection prophylaxis, start your PJP prophylaxis, because this is actually the most common reason or the most common time post-transplant somebody gets a pneumocystis pneumonia. In terms of further diagnostics, you want to make sure that it is not antibody-mediated rejection that you're seeing. So do the respective stains on your biopsies. You can also think of viral PCRs in a situation where you think there could be overlap with a myocarditis. HLA testing is routine for us whenever we see somebody coming with rejection. We would also check for isohemagglutinins if they're ABO incompatible recipients. CRP and NT-proBNP give you a sense of inflammation and heart failure, but are not specific. EBV and CMV PCR because they would have specific treatments. And then the newest kid on the block is donor-derived cell-free DNA that appears to be very sensitive and specific in regards to acute rejection. Probably not as much for graft vasculopathy, but quite useful in comparison probably with biopsy. If you just happen to find your rejection during a routine biopsy that you do at certain time points in your monitoring, then again, make sure you don't miss any possible reason for why they would suddenly be rejecting. In our center, if it's a 2R asymptomatic, we would treat with oral steroid for 3 days. Obviously, if it was 3R, which I have never seen in my career, that you would have an asymptomatic high-grade rejection, then you would go down the same route I just described for symptomatic rejection. In those cases that are asymptomatic, we monitor by echo that everything is good, that they tolerate steroid and seem to go in the right direction. And then within 4 weeks, repeat a biopsy and assure that it has resolved. If we are finding antibodies, then we have to think about treating the B cells. And I'm just showing this to remind you that B cells express CD20, but the plasma cells that actually produce the antibodies do not. And then they produce the antibodies, and at the same time, you have memory response to reactivate at a later time point. So what are the approaches you can use? You can remove the antibodies by plasmapheresis or immune absorption. The latter does not remove all your other proteins, so is better tolerated than plasmapheresis if you have that. IDAS is the newest kid on the block. It's a streptococcal enzyme that splits the FC part from the antigen binding part and basically deactivates all your immune globulins that you have in the blood, all your antibodies immediately. You can only use it one time, but it's a good rescue therapy. You then want to get rid of your B cells, and you can use anti-CD20 antibodies. The prototype is rituximab. But keep in mind, they don't produce the antibodies, and the plasma cells aren't targeted, so it takes 2-3 months until the antibodies will come down. Proteasome inhibitors target the plasma cells directly and deplete them, and therefore have a much faster effect. They also have some effect on memory B cells, but they also have significant adverse effects, so require careful consideration whether to use them. And in the end, you'll end up with a combination of the things, and all of them should always include immune modulation by IVIG, which slows down your antibody production, but also gives you infectious protection at the same time. Another new drug is eculizumab. Eculizumab does not affect the antibodies itself. They are still there and they bind to the antigen, but if they try to activate complement, it blocks the complement cascade downstream, and therefore I don't have any complement-mediated effects of the antibody-mediated rejection. So these strategies and combinations thereof have been shown to be quite effective for acute antibody-mediated rejection. And they're also recommended in the consensus guidelines of the ISHLT as a therapy. But there's actually no good evidence yet what they do in regards to the long-term consequences of the antibodies and whether they can prevent graft vasculopathy progression. The one thing that improves graft vasculopathy progression is switching over from your always in combination given medication of a calcineurin inhibitor, such as tacrolimus, from mycophenolate to mTOR inhibitor, so sirolimus or everolimus. In contrast to mycophenolate, they also have an effect on endothelial cells and therefore reduce the progression of the graft vasculopathy, of the narrowing down of your vessel. And that's been well shown in adult randomized controlled trials. There are some smaller trials that suggest the same effect in children, and there's currently the first probably multi-center randomized controlled trial, the teammate trial that tries to evaluate whether there is an actual benefit for children to use these drugs. Low-dose steroids is commonly done, although there's no good evidence for or against it, so I'm not going to recommend or dispel that. The other things you want to have an eye on is just to make sure your lipids are not unusually high. Statins also have an immune modulating effect. That's why many places will put their patients on a statin once they reach at least teenage. Some of the studies that we've been included with have not shown a clear benefit. However, because the statins are given to the sicker patients, they may still have a benefit by showing similar outcomes between those two groups. You want to keep your blood pressure optimized, and there's no evidence for aspirin, but many places will start giving aspirin once you have graft vasculopathy, just in analogy to coronary heart disease. And lastly, is it reasonable to do CABG or implant stents? Interestingly, in both the adult and pediatric world, the patients that receive stents for graft vasculopathy have worse outcomes than similar patients not receiving an intervention. And it's probably a psychological mistake that we make, because we look at that big vessel and we put a stent in the big vessel, and the big vessel looks nicer, but what happens downstream is unchanged, which is the disease of the smaller vessels and the narrowing that is still present downstream of the stent. Finally, the question, when should we retransplant a patient? The indication is obviously given individual and has to take the overall situation of the patient into account. As mentioned, younger children tend to show faster progression and may need to be listed earlier. If it occurs earlier, it seems to have faster progression as well. If there's an immunological background for why they have developed it, you do not want to do the same thing again. So you want to treat the antibodies, but you also want to avoid transplanting the same heart again that has the same surfaces, and maybe avoid those. It's always important to assess for non-adherence, malabsorption, medication interference, and mental and general well-being of your patients, because if they're not taking the medications you give them, you can have the greatest medications and not going to save your patient. I'm happy to answer questions at a later time, and this is just a picture from our annual heart transplant family camp that we've been able to do for the first time after 3 years again in person this year. Thank you very much.